Yeah, so the main challenge here is that pediatric hospitalization is an inherently dynamic process and risk factors can change throughout admission. So ideally, rather than relying on a single admission assessment, institutions should implement serial or recurrent risk evaluation as clinical status evolves. So that means, for example, having an EMR, electronic medical record based prompt, like every 72 hours, that reminds you to reassess the patient for risk of VTE and risk of bleeding, or developing dynamic risk assessment models like the one that was studied in the CLOUD trial. So with that approach, you recognize that a child that maybe at the time of admission was low risk may become high risk. For example, if they develop an infection and you place a central line or have prolonged immobility, etc., and vice versa, right? A child that you initially categorize as high risk, as the hospitalization progress and their clinical status improve, then that child may go from high risk to low risk. So dynamic evaluation, recurrent evaluation is important. For peri-procedural management specifically, the guidelines actually suggest that institutions should try to develop protocols that balance the bleeding risk of the specific procedure, which is usually categorized as minimal, low to moderate, or high-risk procedures, and balance that against the thrombotic risk of the individual patient and the type of anticoagulant being used for prophylaxis. And something that is a key consideration in children is that pediatric protocols for peri-procedural management of anticoagulation should account for the age of the patient, as we know that, for example, the DOACs have different half-lives, shorter half-lives in younger patients, which may allow shorter interruption intervals compared to an adolescent. And also take into consideration the fact that there's an absence of validated reversal agents in pediatrics. So ideally, institutions can develop standardized peri-procedural protocols that are adapted for the specific pediatric population, thinking about the unique pediatrics, pharmacokinetics, and the specific anticoagulants used for prophylaxis. Yeah, so this is actually something that we've been discussing a lot in the field. So the first thing is that it is important to acknowledge that we definitely have made significant progress in pediatric VTE research. The pediatric DOAC trials, the KidsDOAC trial, despite some limitations, are proof that rigorous randomized controlled trials in pediatric VTE can be completed. However, these trials, despite giving us all these new data and evidence of pediatric VTE, these trials also taught us a lot about what's challenging in trial design and implementation in this area. So things that we're sort of suggesting or looking into are things like the need to use adaptive designs for clinical trials in pediatric VTE, such as things like Bayesian approaches or the parallel cohort contemporaneous control capture design, which is like a mouthful, but it's basically a novel adaptation of parallel cohort RCT, where patients who decline to be randomized or who misspecify are captured into a parallel non-randomized contemporaneous control cohort that augments the randomized population. So instead of looking at retrospective controls, you have a contemporaneous control. And sort of these type of approaches basically improve trial efficacy. Overall, adaptive trial designs can really help us overcome the size limitations that are inherent to pediatric research. The other thing about pediatric VTE trials is that we need to be very mindful careful in selecting our enrollment criteria. On one hand, we know that condition-specific enrollment, sort of targeting homogeneous high-risk populations, like think about all patients with leukemia on induction, or all children who are critically ill and have a central line, or all patients with severe trauma. Like those homogeneous high-risk populations give us the best chance for generating actionable population-specific data. But on the other hand, we've learned that narrow eligibility criteria can lead to recruitment challenges, prolonged study timelines, difficulty generalizing the data. And on the other hand, a broader enrollment criteria can improve feasibility, accelerate accrual, enhance generalizability, but obviously it comes at the cost of diluting any potential treatment effect and making it harder to identify which subgroups are actually able to benefit or truly benefit from anticoagulant prophylaxis. So in this area, I guess there's no perfect answer, but we have learned that at least in the future, we need to very carefully balance this trade-off, be very thoughtful about it, and perhaps consider using adaptive enrichment designs that start broad and then narrow based on interim signals into sort of like more homogeneous high-risk population. Then finally, I think, we know trials need to be age stratified. We talk about developmental hemostasis and how that basically makes the risk profiles for VTE and bleeding different across different age groups, but also age impacts pharmacokinetics and pharmacodynamics of anticoagulants, right, in pediatrics. So it is, which ultimately affect both safety and efficacy of these agents. So it's important to continue to do risk stratified trials, and particularly focusing on enrolling the younger population, which we've seen is the most challenging population to enroll in these trials. Lastly, it is important, however, to recognize that we will not be able to rely on clinical trials alone to generate all the data, all the evidence we need. We need also to continue to build collaborative infrastructure, such as the IPTM, which has the ThromboPET registry for international prospective studies, or efforts such as the CHAT consortium, among others, that can permit to generate real-world the age-specific data that we need. So the truth is that moving forward, it's going to take both the design of rigorous trials, but also strong collaborative infrastructure that allows to conduct robust registries in order to generate this high-quality evidence that we need to guide decisions regarding anticoagulant thromboprophylaxis in pediatric VTE. We do think, though, that the guidelines give us a framework for collecting that information in an interpretable way.